First, I'd like to thank David Thomas and Sharon Strauss, who are the chair and co-chairs. And an incredible program committee, which included 500 volunteer reviewers. It's incredible. And then SGIM's really tireless staff to make this happen, to make this meeting so spectacular. But today we also thank David Carlson as he approaches retirement. David is only the second executive director of SGIM in its 35 years. And when he took the job in 1997, another Clinton, Bill Clinton, was in the news, starting his second term. And according to our demographics, 20% of you were still in high school. So David is fond of saying that he led from behind. That meant he worked with 18 hard-headed, occasionally idiosyncratic, but you know who you are, presidents, and some incredibly diverse councils. Despite that, David has accomplished a huge amount in his 18 years. SGI membership has doubled, despite some actually pretty hard times in general internal medicine at times. JGIM is now the highest rated primary care journal, health journal in the United States. Our annual meeting attendance has exponentially grown. The regions were established, and now regional meetings are actually rivaling attendance at national meetings. The SGIM staff has expanded from 4 to 16, and SGIM is so financially stable that we were actually able to pay off the mortgage this past year and still go into next year in an incredibly good financial shape. David's here with his wife Cinda and their son Matt, and I'm sure their daughter Claire, who couldn't be with us today, is here in spirit. So please join me in thanking David for his long service to SGIM, his accomplishments as 18 years of executive director.
I've always appreciative of been given this opportunity, and little did I know the journey that it would take me on to work with marvelous people all these 18 years. But all these things that Bill said about what we did, it was really the us. Everybody in this room participating, our rank and file members. No group has a greater amount of members come to the meeting, come to regional meetings, and support the society as they do. Without our rank and file, we wouldn't be here. In addition, our volunteer members, Bill mentioned the hundreds of work on the meeting, let alone the myriads of work on all our committees and task forces and our regional meetings. That's hundreds more that make this a member-driven organization. Then there's our volunteer leaders who are so thoughtful each year, figuring out the direction that we need to go to keep SGIM strong as it faces the great challenges and turmoil in medicine. And then I leave you with the staff that's absolutely remarkable. 15 individuals, highly dedicated in sharing your values and supporting everything you do. They're great professionals. And I know they'll leave you, as I leave you, they'll carry on the good flag. And SGIM itself now is very strong, and I was always, over the years, hopeful that we could continue to be very strong to face this great turmoil in healthcare, and you're really prepared to continue that route. And so I leave you and say farewell to you. And I'm so proud to have been SGIM and GIM, and I thank you for everything you've done for me to grow professionally and lead in my own special way. Thank you so much.
Thank you, David. 2 years ago, actually at David's prompting, SGIM Council changed the SGIM tagline to creating value for patients. I want to talk about what that means to us and could mean to our patients, families, and communities. As you know, value, the highest value care is the best quality or outcomes at the lowest cost. But let's for a moment focus on just cost. We've all heard the numbers. I mean, you can probably repeat them in your sleep. United States spends almost twice as much as the next industrial country on healthcare. Per capita, we're now over $9,000 per person. In 2013, healthcare expenditures in the US were $2.4 trillion. $2.4 trillion. How do you put that in context? I mean, it's way more than my retirement account. And you know, the sort of distance metaphor really doesn't help me that much. So you know the one where you line up dollar bills, they would reach 4.6 light years? It doesn't help much at all. But it's also hard to get your head around the fact that two dramatically different organizations, the Institute of Medicine and the Congressional Budget Office, have estimated that we spend 30% of healthcare dollars that don't bring value to patients. Well, actually, that was a nice way to put it. That was the Institute of Medicine. Congressional Budget Office was a little more blunt. They just say waste. So we spend $2.4 trillion, and we waste almost a third of it. So it's easier for me to sort of understand numbers when you think about the impact of these costs on patients, workers, and communities. So this is just an example. In the 10 years from 2000 to 2010, inflation rate was 27%, the bottom line. Real wage growth was 36%. Insurance premiums went up 114%. And employers' contributions to premiums went up 147%. And if you had employer-sponsored coverage, the lower your income, the smaller the proportion of healthcare costs that were covered by your employer-sponsored care program. There's another one. At the state level in 2003, only one state had a cost of healthcare that was more than 20% of median household income. So that meant in West Virginia, $1 in $5 could potentially be going to healthcare. In 2011, only 14 states did not. 36 states, 20% of household income was going to healthcare. 1 in every $5. So there's a lot of other equally dismal statistics about how we transfer cost to our patients and families and communities. And there's another way to look at it. We know that care needs and outcomes for many of our patients are driven by social determinants of health. I think we can all agree that your health and your longevity should not be predetermined by your age, your race, gender, or especially zip code. So what could we do with a small portion of the hundreds of billions of dollars that we waste in healthcare? Economists use the term opportunity cost. And the idea is that resources consumed in one sector, like healthcare, are no longer available to use in another sector, like, say, housing, education, social services. And economists are pretty straightforward. Money's money. Money for healthcare really just comes from personal income, especially if you think that employer-sponsored care is just a substitute for more income, and multiple sources of taxes. Money's fungible. So maybe we need to look at some of the opportunity costs to help us understand the trade-offs. And this helps me get my head around what we're thinking about. So for example, one ED visit is a month's rent. 2 hospitalizations is a year of childcare. 20 MRIs is a social worker. 60 echocardiograms is a teacher. And less than 0.5% of a small academic health center budget is the cost of a new elementary school. We can quibble about the numbers, and we can certainly wonder if those savings could actually be used in another sector. But right now, we can't even have that debate because the money's gone. There is no opportunity. And a large proportion of those dollars are wasted. Now, in 2010, Barack Obama, the president, signed the ACA, and we all sort of breathed a big sigh of relief. Finally, we were going to turn healthcare around. Access would be expanded, the workforce remodeled, financial incentives would be realigned to support innovative care models. We could shift to patient-centered care, moving from volume to value. And Don Berwick eloquently summarized the ACA when he advanced the concept of the triple aim: better health, lower cost, and a better healthcare experience. Well, it's now been 5 years. After legislative roadblocks, countless votes to repeal the ACA, many court rulings, and yes, there was this small computer glitch. There's been a lot of progress. Insurance practices have been reformed, millions of people have gained coverage. The cost curve is bending. Unfortunately, out-of-pocket costs are not bending anywhere near as quickly. And so the savings may actually not be accruing to families and patients yet. But the question is, has healthcare reform hit a tipping point? Is it now inevitable that we'll reform? I don't think so. Healthcare reform is a long-term transformation. I don't think we could expect too much more in 5 years. And it's only going to be sustained if we get costs under control. And, you know, some of you may know, there are still a few folks out there and a couple segments of our industry that haven't fully embraced the ACA and healthcare reform. There's challenges coming up now. The Supreme Court will rule on federal exchanges in a couple months, the next month or so. And then there's this election in 18 months that actually may determine the ACA's future. And keep in mind, 23 states still haven't expanded Medicaid, including my state of South Carolina. So there are still millions of folks without healthcare coverage. Nonetheless, last month, Secretary Burwell issued aggressive Medicare beneficiary targets to enroll beneficiaries in delivery systems that focus on quality and value and alternative payment mechanisms. And then recently, the SGR that passed also reinforces that focus on value and alternative payment mechanisms. So I think the ACA has set the stage, and the government is pushing to continue the transformation despite all this resistance. But lots of our leaders are calling for us to be a little more active, to be participatory in this sort of transformation. We can no longer rely solely on government to advance the healthcare reform agenda. Don Berwick said, it's time to move from change forced from the outside in to change led from the inside out. Michael Porter said in the Harvard Business Review, providers must lead the way in making value the overarching goal. So what do we do in SGIM? ACA policy, ACA aligns with SGIM's values, and specifically our value of social responsibility and equity in health and healthcare. Many members of SGIM are leading healthcare reform efforts, but we all need to play a role. It will be difficult work. So I think SGIM needs to think about doing three things. First, we need to continue to advocate for reform, given the ongoing threats to the ACA. More SGIM members need to join SGIM on Capitol Hill. We need to continue to advocate within the executive branch. Agencies such as CMS, AHRQ, NIH, HRSA, and PCORI. We need to advocate at the state level and at our institutions. I'm sure many of you have had conversations with learners and with patients about healthcare reform. Those conversations need to continue. Advocacy should become part of our daily work. Second, I think we need to embrace the concept of value, to study, practice, and teach how to provide the highest value care for our patients. We have the professional knowledge and skills and have our values to guide us. The people in this room are training the next generation of internists, clinicians, educators, and researchers. And this will be their new professional world. When we bring our values to work, every time we see patients, especially with our teams, every time we teach a student or resident, every time we write a grant or manuscript, we create value for patients. Finally, as we struggle over the coming years, and maybe decades, to eliminate hundreds of billions of dollars in waste and non-value-added care, think about how we will create the opportunity to have the debate that we can't have now. Perhaps the opportunity to reduce the adverse impact of social determinants on the health of our patients, families, and communities. So as we all go home, think of the opportunity we have to create value. Every time we improve access and avoid sending a patient to the ED, it could be a month's rent. If our care coordination avoids 2 hospital admissions, it could be a year of childcare. If we avoid a few dozen imaging procedures, it could be another teacher. And every morning as we walk into the palatial facilities that we call academic health centers, just think that with just a fraction of a percent, we could build a new school. Thank you, and thank SGIM for being such a wonderful organization. So I have one other pleasure. We can advocate for our specialty. And so I hope you're all wearing Proud to be GIM buttons. I have the honor of introducing a preview of the video centerpiece of the Proud to be GIM campaign. This campaign was developed over 2 years by this group, led by Ann Nattinger. I'd like to thank the Hess Foundation for funding the Proud to be GIM campaign. The formal campaign will be launched in September. And the goal is to help first and second year medical students to understand what we do as general internists. So this is the video centerpiece of the Proud to be GIM campaign.